And good morning, everybody.
Morning, Professor Kireki. How are you?
Hi. Good to see you. Good to see you. Yes. At last, our meeting has come.
Yes,
and we've been looking forward to it. Thank you. Thank you so much. My apologies, sincere apologies from COG's side that we had a bit of an issue and we are starting a little bit late.
No
First of all, let me thank you from your side. Do you say University Vatan Kita? Is that the way you say it?
Yes.
I should start learning Malaysian now. Thank you. Thank you so much for making this meeting possible. And we want to appreciate the efforts that you've gone into with our own Susan there. What I want to say to our listeners, and we have quite a number, is that this is a very interesting journey. It's a journey which Susan has started. Most of us have a very wild idea about pediatric adolescent gynecology. Most of us fear talking about pediatric adolescent gynecology, or if we have cases connected with adolescent gynecology, we most of the time don't know where to send them to. And some of us have little or no idea about it. That is why we are so grateful that Susan is there. She's actually a trailblazer in this sense, that you have brought together this team, and you're going to give us an idea about what to do in some of the cases that we actually meet and deal with. So I'm very happy about this. That is number one. Number two, I think this collaboration where we have such meetings, exchange of ideas, what you are doing in Malaysia and what we see here, it definitely makes all of us richer in terms of experience. Number three, the collaboration that Susan has started, she's the first one. I'm sure there are colleagues in our meeting today who could have been wondering, what do we do, or if we wanted to do, a fellowship in pediatric adolescent gynecology, where do we go and how do we start doing it? I want to assure you that from COGS, from where I sit as the president of the Kenyan Obstetrical and Gynecological Society, we are very supportive of this program, and we will support any and everybody who will want to, go into this field, because we don't have any of pediatric adolescent gynecologists in the country. So I'm happy and I'm excited, and let's hear what you have, quote unquote, cooked for us today, Susan and your professors. Thank you very much, and welcome to this CMA.
Thank you very much, Dr. Kireki, for that wonderful welcome note. I would just like to take a moment to just acknowledge Dr. Anne Beatrice Kihara, who is with us, the FIGO president-elect. I saw she said she would be able to join in this meeting. So thank you very much for taking the time, and for everybody for taking your time to join us. We'll just go straight into the program because of time, and we'll have our first speaker, Associate Professor Amelia Zainudinn. She is the head of unit of the PAG department, and she's just going to tell us what is this PAG. When you hear PAG, what is it? What does it entail? Why is it important? Do we need it as a subspecialty, and what common conditions are encountered? Over to you, Prof. Amelia.
Thank you very much, Dr. Susan, for that kind introduction, and thank you very much, Prof. Kireki, for inviting us to have this first joint webinar between Malaysia and Kenya. So as I have only 5 minutes, let me introduce what is pediatric and adolescent gynecology. Okay, what is PAG? So PAG is an emerging subspecialty in the field of obstetrics and gynecology, just as reproductive endocrinology, urogynecology, gynae-oncology, in some parts of the world. So even in Malaysia, we are still actually just trying to have a foothold here. In other parts of the world, of course, like in North America and Europe, they are fairly established. But even in Asia, there's only PAG units in Malaysia, in Hong Kong, in China. And I think there's in Japan and Korea as well, but not that well established. Yeah. However, the ones in China and Hong Kong and Philippines are very established. So our patients are from birth to ages 21 years old, and PAG provides essential obstetrics and gynecological services to these young women. Okay, what are the common cases we manage? So we manage girls with menstrual disorders. They present to us with amenorrhea, primary and secondary, with a dysmenorrhea, with irregular cycles, with heavy menstrual bleed, and also we see quite a few girls with special needs. We also see girls with differences or disorders of sex development, such as those with congenital hyperplasia, mixed gonadal dysgenesis, and sex chromosomal disorders. So these are all very rare diseases. However, because we are the main referral center, we see quite a lot of them. And so with this, we gain a lot of experience in managing these patients. And of course, we see gynecological problems in children, such as vulvar vaginitis, labral adhesions, adnexal masses, imperforate hymen, urethral prolapse, and vaginal tumors. The cases we manage also include pubertal problems, so both precocious and delayed puberty. So delayed puberty can be because of many reasons, chronic disease such as thalassemia major, juvenile diabetes, cancer, so forth. We also are part of the SCAN team, and we are the technical team support. We examine patients who are referred to us with alleged sexual abuse. And we also manage teenage pregnancies. We provide antenatal, intrapartum, and postnatal care, counsel on contraception, and treating their STIs. What are the surgeries we do? We see girls with ovarian cyst accidents. So this is an example of torsion of ovarian cyst, one of our own cases. We do a lot of examination under anesthesia for girls with disorders of sex development, with girls with vaginal atresia, for example, with sexual abuse, or with abnormal genitalia. We also perform laparoscopic and sometimes even open gonadectomies for those with the XY females. And you see, this is one of our patients with vaginal atresia. We also perform ablation of neovaginas and also manage those with vaginal septums. We perform vaginal septotomies. And we also manage girls with adnexal masses, surgeries on them. We work with a lot of other disciplines. As I mentioned just now, the SCAN team, so child sexual abuse together with pediatricians, the child and teen mental health experts, social workers, child protection services, police, and forensic. We actually now, our center is starting to provide oncofertility. That means fertility preservation in children and adolescents with cancers. So we work together with the reproductive endocrinology teams, oncologists, gynecologists, and pathologists. We also manage patients with gender dysphoria. And we work together with the endocrinologists, pediatric surgeons, urologists, geneticists, and even the religious scholars and mental health experts. And we also have dedicated DSD teams where we see patients with ambiguous genitalia cases, CAH, Turner syndromes, and so forth. And we work together with the geneticists, pediatric surgeons, pediatric and adult endocrinologists, urologists in managing them. And we liaise with support groups such as MRKH Malaysia and Turner Syndrome Malaysia, which were just established. And at least once a month, we have our radiological conferences with this. So this is a Zoom meeting, a radiological conference with Dr. Erica here. You can see her here, and this is us, where we look at complex Mullerian abnormalities. And this radiological meeting is very important, actually, for us to review the MRI, the CT scans, the ultrasound scans together. And this enables us to plan for further management. So this is us. This is Susan here, operating on this girl. And you can see this girl, she's got uterine didelphys, 2 uteruses, and 1 is obstructed. This is filled with old menstrual blood. Yeah, so we had to do a hemihysterectomy in this patient. Okay, we also provide public education. We have public forums. We give talks to schools, and then we also engage the mass media. And this is mainly to educate the layman, the public, about what services we provide. And then, as I said earlier, we form liaisons with patient support groups, And we've created some information pamphlets in different languages to give to our patients. This is the book that myself and Prof. Azurah just only published. This is Paediatric and Adolescent Gynaecology for Trainees, case-based discussion. So this is Azurah's daughter, and this is my daughter. They're both the same age. Our unit also trained our postgraduates. We train the master's candidates in ONG because we realized that actually there's very little education. PhD is not really part of the medical curricula in both the undergraduate and postgraduate curriculums. So we are now beginning to introduce it into curriculum so that people are more aware. This is also to make sure that patients are better diagnosed and also remove the stigma. How we do this? Of course, they join us in the clinics, in the operations, but also we also have monthly Zoom case presentations and discussions, which we will open nationwide. We are currently in the process of setting up a national training program for this subspecialty with the Ministry of Health. And our university, our faculty has a UKM fellowship program that trains both national and international fellows. So Susan is our second international fellow. Our first was Dr. Ifat Ahmad from Pakistan. Our center is an accredited training center for Paediatric and Adolescent Gynaecology Fellowship by the International Federation of Juvenile and Infant Gynecology, FIGGIG. So this is the biggest PAG body in the world, and so we are an accredited center by them. Yeah. So if anybody wants to train, they come to us for 2 years, and then they can sit for the exams. But Professor Nur Azurah will go into more detail. If you wish to apply for a clinical fellowship program in UKM, this is the website. This is the URL link. Okay, so this is the center here in the website of FIGGIG. Okay, we also conduct research. So we've actually introduced Susan to a lot of research. She started doing systematic reviews now. She's teaching me actually how to do it. We also publish in peer-reviewed journals, and we present in scientific congresses. So this is Susan presenting at the 3rd Malaysian Advances in Women's Health Congress that we held last year. This is the entire PAG team. And this is us in the World Congress in Melbourne in 2019. And we also actively participate in the Asia-Oceanic Society for PAG. So this Asia-Oceanic Society of PAG was established in 2017. It consists of 11 countries, and we've been quite active for the past 3 years. So we are hoping that Susan will establish the first African or Kenyan society for PAG. Okay, we also have a lot of fun. So we have outing. We celebrate each other's birthdays. And we have yearly outings as a team. So this one recently organized by Esther. The whole team went to Sikinchan. We looked at the beautiful paddy fields of Malaysia. We had a nice round, and we went swimming and so forth. And this is a picture of Susan courageously having a taste of the durian cendol. So I don't know whether you all know what durian is. Durian is the king of fruits. It's very, very delicious to me and my other colleagues, but some people cannot take the smell. But I'm not sure whether Susan enjoyed it or not. She bravely took the first bite though. Okay, so that's my introduction to PAG. Thank you very much. I'll stop.
Thank you so much, Prof. Amelia, for that brief PAG overview. If anyone has any questions or any comments, you can just put them in the chat box, or you can ask at the end. We'll have a Q&A session. That was very informative, though brief. I would now like to take a chance to welcome the Head of Department of Obstetrics and Gynecology, but also a PAG specialist, Professor Nur Azurah Abdul, who is just going to give a brief overview about PAG training. What does the training entail, the fellowship program? What rotations are there in the PAG training? Over to you, Prof. Azurah.
Thank you, Susan. Assalamualaikum, and very good evening to you guys in Kenya, but it's actually almost midnight in Malaysia. So thank you, Susan, again for the kind introduction. And I actually would like to thank Professor Kiriki for inviting us to join this webinar. As Amelia said, this is probably the first step in many more collaboration between Malaysia and also Kenya. So I've been asked to talk about training in Pediatric Adolescent Gynae. So we call it PAG in short. As Amelia mentioned, the IFA-PAC is actually the main body that actually helps to train the PAG. Right? So basically, the IFA-PAC, they actually have a pool of people, healthcare providers who are passionate in terms of treating or treating these young girls and adolescents. So IFA-PAC is actually the main body. They have a website that you can actually go into, and there you will see a lot of activities, conferences which is related to PAG. The next World Conference is actually going to be held in Serbia somewhere in May. And I think most of the girls in Malaysia are going to that conferences. And I think Susan is eyeing to go for the EuroPAC, which is going to be held somewhere in October, if I'm not mistaken. So there's a lot of conferences related to PAG. Because when I started doing PAG, I didn't have any idea actually where I could be trained. So we were like looking here and there, and finally we found a place which is the Harvard. They organized a workshop on PAG. So that was actually our first exposure in 2006. So now they are more organized, so you can actually look up into their website, the IFA-PAC website. The IFA-PAC website, so they actually provide bursary to those who are interested to be trained in PAG. I guess Susan missed the boat because she was already in the program, and then when the announcement came out, when we tried to apply, they said she can't take up the offer because she was already in the program. For those who are interested to pursue in PAG, probably you can look up into this website, the PG website, the IFA-PAC, look for the bursary. They actually give about for the training. All right, but usually they will give half before and half after the completion. You might say that, well, it doesn't cover everything, but it does help. I mean, I'm sure from the ministry or the university that you're working, they will provide, but sometimes for me, as a Malaysian, I was trained in Melbourne. So the difference in the currency actually makes a lot of difference, because whatever money that I earn here, when I convert into the Aussie dollar, that's not much actually. So having additional help actually can go a long way. All right, so as in the website, you will see a list of training center. All right, so these are from all the centers. These on this side is actually the Asian country. So Malaysia is one of the listed center for the training. So you can actually choose a lot wherever that is feasible for you, convenient for you and your family. All right. As I mentioned, the IFA-PAC, they have exam. It's good to take, but it's not compulsory. But we do encourage all our trainees to eventually take for the exam. For myself and Prof. Amelia, we didn't take the exam many years after we've already completed our training. Because initially we didn't think that it was important, but later on we realized that we need to be in the society, and we wanted our center to be accredited for the training center. Hence, we actually sat for the exam. So for the exam, to sit for the exam, you need at least 2 years of experience in PAG, and you have to submit 10 case report before you can sit for the Part 1 exam. You have to submit another 10 case report before you can sit for the Part 2. For example, the pediatrician, the physician, they can actually sit for the Part 1, because Part 1 is basically medically related problem in PAG. Alright, so these are MCQs for about 50 MCQs. So to pass part 1, you need more than 60%. Right? Part 2 is more on the surgical aspect of the PAG. It's again about 50 MCQs and you need to have more than 60% to pass. All right. Once you pass part 1 and part 2, then you'll be called for the part 3. So part 3 basically is just a viva section with the examiner. So basically to discuss the case that you have written. So to look whether you have to understand and see. So you can get more detail actually from this website, and you can actually contact Associate Professor Dr. Simferosa Chan. She actually is the exam director. She's based in Hong Kong. So UKM itself, we have 2 hospitals. This is a general hospital and this is the pediatric hospital which just recently opened. So it's actually next to each other. You can walk across. So we do have clinic in both the general and also the pediatric. So the general, because we do have a patient who once had a PAG problem, but their age is more than 18. So we continue to see them in the general in a general hospital, but still we call it a PAG clinic. So we actually have 2 PAG clinics.
Family ni kujengana. Visit anyone.
Explains to apply to do fellowship, you can actually go into the website. There's under the program, you click at the clinical fellowship. So go to the surgical one, and at the drop down, you will see the list of the fellowship that's offered in the ONG department. So PAG is one of those. All right. And sorry. So basically, when you do PAG, Amelia has laid out all the cases that we see, but we actually don't stop just seeing the gynae cases. We actually ask our trainee to rotate to the adolescent physician clinic, basically looking at the, for example, cases like anorexia nervosa and obesity. And then we actually ask them to rotate themselves at the endocrine. Peds endocrine, because some of our cases are very much related to the peds endocrine. So it's good that they have the exposure there. Okay. I think that's about it. So basically join us in the community of PAG. So because together we can actually provide a better care and a holistic care to our younger girls. Thank you.
Thank you so much, Prof. Azurah, for that wonderful presentation. Thank you. I hope we are all still together. That was very enlightening, and I hope it's, going to encourage more and more people to follow up with this fellowship. We'll go into the next phase of this presentation, where we'll just, both Prof. Amelia and Prof. Azurah will just tantalize our taste buds a little bit, just to give, just a few cases, interesting cases, controversial cases that we've come across. And we'll start with Prof. Amelia. Over to you.
Okay, thank you very much, Susan. So I'll just give a brief talk on menstrual health management in girls with special needs. So we see a lot of girls with special needs in our clinic. Okay, so this will be the outline of my presentation today. What are girls with special needs, their puberty, their menstrual issues, what is our approach to management, what are our options of management, and the conclusions. It's going to be a very brief talk because it's only 10 minutes, but this is just to give you a brief overview. Okay, so what do we mean by special needs? So typically, individuals with special needs may have been born with a syndrome, terminal illness, profound cognitive impairment, or serious psychiatric problems. But other individuals who are also considered as special needs may involve those struggling with learning disabilities, food allergies, developmental delays, or panic attacks. Okay, now the definition of a disabled person. So when we think about special needs, we are more thinking about the disabled individual. So this is a person who experiences a loss, a change, or abnormality of any parts of the body, nervous system, organ functions, or limitation of physical or mental abilities. A disability may be present from birth or occur later in life and may be permanent or temporary in nature. And this condition prevents the person from participating fully in society, from performing basic daily activity and functions, and interacting with society in the physical and cultural environment. So there are many, many types of disabilities, the sight impairment, speech, hearing impairment, physical disability, mental disorder, multiple disabilities, slow learners, and autism. And all of these we see in our clinic. Okay, now in terms of puberty and menarche in these patients, so children with cerebral palsy may undergo puberty a bit earlier compared to the general population. However, the menarche may be the same or later. Girls with spina bifida and other neurological impairments tend to have earlier menarche. Those with severe disabilities, global developmental delays, or failure to thrive tend to have delayed puberty. However, actually, the age of menarche for women with disabilities is the same as the general population. So generally, worldwide, the age of menarche between 12 to 13 is about 12. And so it's actually the same for girls with disabilities or girls with special needs. So when I think about what are menstrual issues in girls with special needs, they're mainly coming into three categories. One is their menstrual hygiene, two, premenstrual syndrome, and three is the increased risk of sexual abuse. So just to illustrate these issues, I put in a case scenario, actual cases of examples that we see in our clinic. So in terms of menstrual hygiene, we had a 10-year-old with autism that's used to smear her menstrual blood on the walls at her school. Yeah, so of course this caused a lot of distress not only to the parents but also to the teachers and the other classmates. Yeah. Now in terms of premenstrual syndrome, we also had an 11-year-old girl who was not able to communicate. She had a cerebral palsy, and she was also quadriplegic, and she was fully dependent on her mother. And then her mother would tell us that she used to hit her head and have increased seizures when she's about to start her menses. Yeah. And then the third category in terms of sexual abuse, we had a 17-year-old who was actually very clever. She used to be she was the top student in her school, but she had a physical disability. She had spina bifida, and which made her a bit slow in her movements. So what happened was she would, to go up and down the stairs in school, it would take her a long time. So she used to be embarrassed about this. So she would wait until everybody goes home. Then only she would climb down the stairs to go home. So somebody must have been watching her, and she got raped at the staircase at her school, but she never told anyone. And she presented to us when she was already 5 months pregnant. And she herself did not know that she was pregnant. But she had actually kept or suppressed that tragic incident in her mind, and even her parents did not know. Yeah, so we have had a few cases of girls with special needs who were sexually abused and who got pregnant as well. Okay, now apart from those three issues, of course, they also suffer from other menstrual disorders. So some adolescents with developmental delays may be more prone to abnormal uterine bleeding, heavy menstrual bleeding, or irregular periods. Yeah, they also can have dysmenorrhea. So we've had a few girls with obstructive Mullerian abnormalities, and they also have premenstrual syndrome more compared to their peers. Yeah, there are some genetic syndromes such as Prader-Willi syndrome or Lawrence-Boone syndrome, which are associated with intellectual disability and hypogonadism. So we've got a girl with Prader-Willi syndrome who doesn't have, she's got hypogonadism, so she doesn't produce any estrogen, so she doesn't have menses. So we have to give her hormonal replacement therapy. We also have girls with autism more likely to present with premenstrual dysmorphic disorder and dysmenorrhea. So I remember we had one 15-year-old girl who, when she came to the clinic, she was having her PMS at that time, and she was actually rolling on the floor because she was very distressed with the premenstrual syndrome. Yeah? And of course, hypothyroidism in Down syndrome patients may cause amenorrhea or even the opposite, abnormal uterine bleeding. Yeah? And of course, medications that these patients are on can also affect the menses, such as antiactive and Urolac. Okay. So this is a publication that was published by our unit. It was carried out by Dr. Nur Khairul Nisa, who was our fellow, who finished training with us last year and has set up her own PAG clinic in the East Coast of Malaysia in Kuantan. Okay, and so this study was a questionnaire which we gave to parents and guardians who attended the public forum that we had organized in 2012. So this study was actually headed by Prof. Azurah. This study aimed to describe the menstrual pattern and care of girls with intellectual disabilities and to evaluate the impact of menstruation and awareness of parents and guardians on these girls. As many as 123 parents and guardians participated, and the girls were between 9 to 17 years old. Mean age was 12.28 plus 2.78 years. So they consisted of girls with Down syndrome, with autism, with cerebral palsy, and with slow learners. And if you look at the table here, so about 41%, so equal numbers were able to manage menses either without help or with help. However, as many as 16.2% of the girls were not able to manage their menses at all. Yeah, and then of course here 81.1% of those responding to the questionnaire who actually filled in the questionnaire was the main person responsible for assisting the girl during the menses, and only 10.8% were actually helped by the partners. In terms of seeking medical help to managing the menstrual issues, a great big 78.4% never had medical help. Yeah, and all these girls had NAPI by the time they sought medical help. And unfortunately, doctors were only provided information to 4.5% of them. And in terms of what type of medical treatment they used in managing the menstrual health issues, 37.5% used painkillers, 58.3% used Depo-Provera, and 4.2% used the progesterone. However, none of them used the COCP and hysterectomy. So this is different from the Australian study. The Australian study, the main medication that was used to manage the menstrual health of the girls with developmental delays was COCP. Yeah, but however, you can see that the parents worried about sexual abuse, 91.9%, and but 7.2% requested for sterilization. Okay, so this is the Australian study done, I think 2007, published in 2017 by Irene Chua. Irene Chua is actually a pediatrician from Malaysia. She must have gone and trained there. So this study was a retrospective review of 80 girls with developmental delay who attended this PAG clinic in Australia. And you can see that these girls, 35% were pre-menarche, had not yet attained menarche, and 65% had gained menarche. So this is similar to us also in the clinic scenario. We do have patients, parents, guardians coming with their daughters to see us before the girls attain menarche because they fear the onset of menstruation in the girls. They fear that they cannot cope with handling the menstrual issues. Yeah, in some cases, they are also sent to us by their doctors managing them, asking us to suppress the menses. Okay, so here you can see that all of them wanted antidisciplinary advice. Some of them had heavy bleeding, behavioral change, hygiene, pain, and increased seizure frequency. And there was increased risk of sexual abuse vulnerability as well. And some even wanted contraception. Okay, so what is the approach to management? One is you have to put aside time towards these girls and carers. Yeah, of course, it is. You have to you need to educate them, to ask to clarify the concerns. Yeah, then if the girls who are okay cognitively, you can have some time alone with them also. Yeah, so you need to get the history, the past medical history, what are the function, what are the capabilities, can they understand what's going on. So you need to know about the cognitive function, the physical function, yeah. How much care do they need? How much help do they need? Of course, what medications they need, they are on. You need to clarify what is exactly the problem or concern, because it varies from patient to patient. So a patient may have a concern of they want contraception. Another one may have heavy menstrual bleeding. Another one may not actually have a period at all. Now, in terms of these girls, of course, we examine them, but internal pelvic examinations are rarely indicated, unless there's a specific problem related to the area of the abnormal vaginal discharge, so forth. But investigations, if required, can do ultrasound scan and full blood count. And then in many of these cases, we may need to liaise with the other disciplines that also are involved in their care. For example, the neurologists and cardiologists, to make sure that it's okay for us to start them on the hormonal therapies and to find out whether, what is happening to them in terms of care by the other disciplines. Now, in terms of the management options, we give education. So we also teach the parents, advise the parents to teach the girls about menstruation, to preempt them, so that they're not so frightened when they first get their menses. So to show them also how to use to tell the children that it's perfectly normal to have menses, that it happens once a month, that it means that you're growing up, you're going to become an adult soon. And then also to teach them how to use the pads, take them to the supermarket, show them the pads, show them the different sizes, show them how to put it on, So these are for the girls who have a higher cognitive ability. And then quite often when they preempt this, they educate the girls beforehand. Of course, it takes a longer learning curve for these girls to learn how to handle the menses, to know what to expect, but they do get it eventually, most of them. And of course, in some of the parents, we give them advice, reassurance. We tell them that we are here to support them. It is not recommended to suppress menses before they start the menses. So we will tell the parents, we will not suppress the menses yet. Let you and the girl experience the menses and see how you cope. And in most cases, actually, they can cope quite well. They come back to us and say, "Oh, my girl got her period, and actually it was okay. I put an extra pad in her Pampers, for example, for a girl who's completely dependent, and I just need to take I need to change the Pampers more frequently." Or in some girls, what the one father did was he knows that the girl is going to have a period. He already put in pads in the girl's underwear, so that when the girl takes the underwear she already has a pad inside. And then some of them they just need our support to know that we are here to help them. We can also use simple non-pharmacological strategies like rest and warm packs and hot water bottle, and even simple analgesia like paracetamol. And then sometimes just one paracetamol during the first day of the menses when they have mild dysmenorrhea helps. And then, of course, non-steroidal anti-inflammatory drugs to reduce the menstrual flow by 35% for those who have a bit of heavier bleed, and also for those with a bit more pain. But of course, we have to be a bit careful with those girls with kidney abnormalities. Those with heavy menstrual bleed can give tranexamic acid, and COCs you can give continuously if you want to suppress the period completely, or you can give cyclically. You can mash it and put it inside their food. It's actually not advised to give the patch because it gives them a higher dose of the estrogen. But I must say that but the COC you have to be a bit careful when with girls with the anti-epileptics. So in girls who are completely immobile, sometimes I can be a bit hesitant about giving them COC because there is theoretically a bit of an increased risk of DVT, venous thromboembolism. However, we don't have any data yet about the prevalence of VTE in these girls. But then I do remember when I was training in Australia, there was one 14-year-old with Down syndrome who actually did have a DVT, but because she was already treated for the DVT, Professor Sonia Grover, the one who trained us, myself and Azurah, she still continued with the COC, because the girl was already on treatment. Another very popular treatment is putting in the Mirena. So of course, when you first tell the parents that to suggest the Mirena, they get a bit frightened and say, "Why do you want to put something into my girl's uterus?" But we do this under GA, general anesthetic. So the girl comes in, is admitted, and then we take her to the theatre, give her general anesthetic, and just put in the Mirena. And this is not a problem because if the uterus is big enough for them to have a period, it's big enough for them to have a Mirena inserted. Of course, they may have a bit of cramps for the first few days after, But in a lot of cases, the parents are very happy with the Mirena because after the first few months of irregular bleeding, then they are almost completely amenorrheic. So it gives a break to the parents and the carers and the girls who suffer from the severe menstrual issues. And of course, it's a contraception as well. And then medroxy progesterone acetate. As you can see in the case series that we published, a lot of them were on the Depo-Provera. However, a bit more hesitant in giving these girls the Depo-Provera because it can affect their bone mineral density. So we may have to give additional calcium and vitamin D to them. And then we do use the Provera tablets as well to reduce the heavy menstrual bleed. But in terms of the implant, it's not very good for these girls because it causes irregular bleeding. Of course, the very last resort is surgery. We don't have that many parents asking for hysterectomies. But it's the absolute last resort, So in countries like Australia, you need a court order to perform a hysterectomy on a disabled girl. But in Malaysia, you don't. But in saying that, we have, we've had 2 or 3 cases of girls with disabilities who had obstructive Mullerian anomalies. That means they had, they didn't have vaginas or cervices, and the blood was stuck inside the uterus, and this girl suffered from severe pain and had no quality of life and had repeated surgeries. So in those very rare cases, after extensive counseling of the parents, we did perform hysterectomies, and we actually did get input from our lawyers as well. Okay, but this is the absolute last resort. Okay, so on conclusion, girls with special needs undergo puberty and menstruation just like other girls. The main issues in their menstrual health management are menstrual hygiene, premenstrual syndrome, and risk of sexual abuse. They may also have other menstrual disorders such as abnormal uterine bleeding, dysmenorrhea, and oligoamenorrhea. And the healthcare provider needs to ascertain the concerns of the carers and the girls, educate and manage the patients on a case-by-case basis, and be supportive. With that, I thank you very much.
All right. Thank you. Thank you so much, Prof. Amelia, for that very enlightening presentation on menstrual health management in girls with special needs. For those who are just joining us in, welcome. We are just continuing on with the program. And just because of time, we want to proceed to the next presentation by Prof. Azurah on Ovira, Mullerian tract obstruction. Thank you, Prof. Azurah.
Thanks, Susan. Hello, everyone again. Just putting on the slides. All right. So this evening, I'm going to talk about the Mullerian tract obstruction, basically Ovira. Ovira actually stands for obstructed hemivaginal ipsilateral renal anomaly. Previously, it was said to be renal agenesis, but then along the way, they found that not all patients has absent kidneys, so some of them has abnormal kidneys. So the term has been changed to renal anomaly. Right. So when we talk about the Mullerian tract obstruction, there are 2 situations. For example, if the girl has never had any menses before, usually they will present to you with cyclical abdominal pain. All right. So they will have pain on certain days of the month, and then again the pain will recur the month later. So it will be more of like cyclical. If you keep track of the pain pattern, you will notice that it's more of a cyclical pain. All right. But if the girl has already had menses, these girls usually will present with severe dysmenorrhea a few months after they have already attained their menarche. For example, like maybe about 2 to 3 months before that, they had their first period. Now they're experiencing severe pain, severe dysmenorrhea. One thing that we have to understand that normal girls, usually do not have pain, do not have dysmenorrhea for the first probably about 3 to 5 years. All right. Usually the dysmenorrhea, the primary dysmenorrhea will only occur once the girl is in the ovulatory cycle. That means once the cycle is regular, then they will start to experience primary dysmenorrhea. And usually that pain will only last probably about 1 or 2 days. Okay. But the girls with Mullerian abnormality, usually the pain is very severe. So that to the whole length of the cycle, the whole length. That, for example, if they are bleeding for 5 days or 7 days, that means for the 5 days, 7 days, they will have severe pain. So that should ring a bell that something is wrong. Maybe there's an obstruction somewhere. All right, just because they have menses, it doesn't mean that there's no obstruction. Okay, and in both situations, in both scenarios, some of these girls will present with abdominal mass, especially if you detect it late. Previously, before I did PAG, I've never heard about Overa. I've never heard about the term Overa before. All right, but now we're seeing more and more cases. And previously, the cases were diagnosed a bit late because there was no awareness among the doctors. But Alhamdulillah, with the awareness of more doctors, awareness of more of our trainees who eventually pass and become specialists in their hospital, they refer cases. So we do see a lot of rare cases. We do see cervical agenesis or dysgenesis, and some of these cervical agenesis, they have also vaginal agenesis. So that makes things a bit more difficult. All right. Some of the cases that we see are the transverse vaginal septum, and we also see the imperfected hymen. So just sharing a case that we've managed. So we've got a 14-year-old girl who presented with severe dysmenorrhea for the past 3 months. And she actually attained her menses about 6 months ago. And this was associated with abdominal distension. The breast and pubic hair examination revealed tenor stage 3 to 4. And there was a mass felt equivalent to a 14 weeks size. So if you look at the MRI here, we can see that she has 2 uterus, the right and also the left. Okay, the left side, okay, there's an obstruction here. So there's a what we call a hematocolpus. All right, so there's a collection of blood inside the vagina. So Overa, obstructed hemivagina ipsilateral renal anomaly, is actually an uncommon entity of the tract defect, affecting about 1 in 200,000 girls worldwide. Previously, it was actually known as Herling-Wunderlich syndrome. And for the uterine anomaly, it's sometimes you can see a bicornate, sometimes you see a didelphi, and sometimes it's a septated uterus. And for the renal problem, renal agenesis is a more common one, but sometimes you do see horseshoe or pelvic kidney, cystic renal dysplasia, or the duplication of the collecting system. And sometimes you see the ectopic ureter. So in Overa itself, there are several variants. So the more common one is actually the one that has the low septum. So this one has a low septum, whereby when they present, the collection of blood is more at the vagina. You might get some into the uterus, but most of the time the vagina will be grossly distended. All right, and they will be very minimal inside the uterus. Whereas a high septum, right, the high septum, the collection of blood is mainly the hematometra within the uterus, and then it goes into the tube. Even the tubes are dilated. There will be like a very minimal amount of blood in the vagina. So very minimal hematocolpus, but huge hematometra. So the high septum is the one which is more difficult to treat, and because their septums are much thicker. This one, the septums are a bit thinner, so you can actually approach from below. So let me just show you the difference in terms of how we manage. That's why the MRI, the discussion with the radiologist is very important, so that we can actually plan in terms of what type of approach. Are we going through the vagina, or do we have to go from the top and also from the bottom? So if we have a low septum where the collection is more towards the within the vagina, we can actually approach from the vagina itself, right, without going from the top. All right, so what we do is actually we make a small leak, and then we push in the Foley catheter, and we balloon up we take the balloon. basically it gives you the area on how much you can dissect, because you need to dissect the septum. Because if you just make a neck, initially you see a bulge, but once you make a neck, all the out, so you won't know how much tissue you have to excise, because everything has come out. So it's good that we put in the polycatheter, so that once you inflate it, and then you can pull, so you can see the shape of the balloon, so you know how much to cut. All right. So the high septum, we actually need the help from the top. Okay, you can go through laparoscopically, or in most cases we do as the laparotomy because of the angulation of the dilator. So what we do is actually we make a nick on the fundus of the side that is obstructed, push in the Haga dilator, all right, and that Haga dilator will go through the cervix and then into the vagina. All right, and then from the bottom, so you actually need two surgeons, one from the top and one from below. So the surgeon from the bottom, so they can feel the Haga, and that's where you make the cuts. All right, but mind you, as I mentioned earlier, this septum is much thicker as compared to this one, so it's a bit more difficult. That's why the risk of restenosis is higher in the higher septum. Right, sometimes you have to do repeated surgery again and again, then because the closure, and then the area is also very small. Then not as compared to this one, you have a more wider area to do your surgery, and also your resection is a whole lot more tissue that you remove. But here it's actually a very small space. So if you're doing the high septum and the septum is very thick, we don't encourage to do end-to-end closure. So you have to do what we call a Z-plasty technique. So imagine that this is from the vagina and this is the upper part. All right, so you're approaching from the vagina, so you have to make an X mark. All right, so you make an X mark and then you tunnel your way up until you feel the upper part of the septum. So here you do a plus mark. All right, so it has to be, this one is a X, all right, so this is a plus, okay? So basically we're trying to pull the edge, the apex here to the edge here. So you have to suture it together so it becomes like this. So basically it's a tunnel, to make it tunnel, so that it will reduce the risk of stenosis. Because if you just do end to end, that means you bring the tissue together, because there's a lot of there's a huge amount of tissue in between. So when you try to pull, when you suture, it's fine, but after a while the suture will dissolve and it will go back to here and it will close again. The upper part will close again. All right, so that's why we need to do the Z-plasty, whereby you kind of like interlace it in between, so the area remains to be patent. I think that covers. I hope that I've explained a little bit. It's not. I mean, we do get. We get referral from the other hospitals, so in time we get better in terms of our surgery, in terms of our outcome. But let me say this, it's not an easy case to manage. So sometimes you've seen one case and you think the second case is similar, but it's not. It always comes with almost different abnormality, but you probably have. That's why you need a good team, especially with the radiologist, so that you can actually plan in terms of surgery. That's it. Thank you very much.
Thank you very much, Prof. Azurah, for giving us a talk about Ovira. Actually, I also heard about Ovira the first time when I joined the PAG unit, and I remember it was my first ever surgical case, and Prof. Amelia asked me, "Oh, have you heard about Ovira?" And I said, well, what all medical students say when they've been asked a question and they don't know the answer, I just said I'll look it up. So thank you for that talk. For those who are just joining us, don't worry, we are actually recording this meeting. We've had a few very informative sessions about PAG, what it is, how to join the fellowship, the exams, what the training is all about. So we are just coming to the tail end of the meeting, where I am actually going to give a presentation on my personal experience doing this fellowship in Malaysia. So of course, it's not easy to talk after your bosses have spoken, but I'll give it my best shot. Okay, so I hope we can all see my screen. All right. I just decided to put the famous Petronas Twin Towers that Malaysia's Kuala Lumpur is actually known for, with the tagline of Malaysia, truly Asia, as my opening page. I remember when I left home and I was talking to my relatives and telling them that I'm leaving Kenya for Malaysia. I told one of my uncles, he asked me, so what are you going to do there? And I told him I'm going to do a fellowship in PAG. And he said, oh, so you're changing to theology. You're becoming a theologian. I said, huh? What does that mean? And we later laughed about it because in some communities in Kenya, PAG is actually a church, the Pentecostal Assemblies of God. So my uncle actually thought I was coming to fellowship with other parishioners in a PAG church in Malaysia. So we laugh about it until today. He calls me and asks me, so how is the fellowship going? So that is a running joke. How I came across this fellowship is a story for a book. I can't even go to it right now. But as I was going through my journey of applying for places, as the people who were in the meeting with us earlier, when Prof. Azurah and Prof. Amelia mentioned how it was so difficult to find a training center because it's still a novel subspecialty. Most countries are actually keen on training their own. I actually applied to 30 different centers and I got 30 rejections. And then the 31st center, that was Malaysia, Kuala Lumpur, actually accepted to take me on as a fellow. So this is the hospital. I think most of you have seen it. It's equivalent to a level 6 hospital in Kenya, the National Teaching, Referral and Research Hospital. This is where we see our over 12 patients. We do our cases here. Our theaters are here, clinics, wards. And beside it is the pediatric hospital. We like to joke around that it looks like a stack of Legos, Legoland. It is where we see our patients below 12 years and below. We also have wards here. All the pediatric specialties, by the way, are based in this hospital. So when we rotate, because we also rotate in pediatric endocrinology, then we also do that here. When we admit any case below 12 years, we see them here. When we have our clinics, we have them here as well. This is just the lobby of the hospital. By the way, this is a government facility. It's very beautiful. This was our first week, I think our first or second week, my first or second week here. So just wanted to let you see how the hospital looks like. For those who've been wondering, will we be allowed to carry out procedures if you were to join this fellowship? The answer is yes. Our professors are very supportive, but they don't just let you sit back. You have to assist, you have to perform surgeries. It's a very hands-on training, as you can see through our photos there. I'm sure someone is going to ask, is it an all-female specialty? We shall answer that at the end. I'd like to I took this photo with one of our patients, a beautiful girl, the one in the Mickey Mouse shirt, just to emphasize how when you manage your pediatric and adolescent patients, it's more than just talking about their reproductive health. We are actually like mentors to them. We end up, because we have to talk about their social health, of course, their sexual and reproductive health, their mental health, and they end up being our friends. This particular patient is actually a very good friend of mine. We actually managed her as a team. So it's really an all-rounded fellowship. And even as Prof. Amelia mentioned, we also have to do rotation in adolescent medicine so that we learn about things like anorexia nervosa, obesity, and how they affect the menstrual cycle and the reproductive health system as well. I cannot forget about this conference because my second week here, Prof. Amelia just told me, there's a conference coming up in Advances in Women, and you're going to present. And I remember looking at her and thinking, I haven't even learned how to, I have barely, gotten used to the weather here, though they have very good weather. And she basically threw me into it. She was like, you don't have all the time here. So, let's get on with it. So the program is 70% clinical and 30% research. Of course, we worked together with the other fellows, and through this presentation, I was able to win an award. And so it's been an eye-opening experience since then. There are several other conferences coming up that we are all intending to attend. And in each conference, it is expected that we should present. At the end of the fellowship program, we should have published, I think, 3. I could be wrong, 3 papers and presented in an international conference. So it's really life-changing. It's really amazing. Of course, it's not all work and no play. I just wanted to show you a photo of where I'm staying, because I'm sure that question is going to come up. What's the cost of living in Malaysia? It's a beautiful place. It's about 2 kilometers from the hospital. My boss has actually helped me get this place. And for the amenities that I enjoy, it's very easy on the pocket. I like to say Malaysia is an interesting country. It has a high quality of living, high standard of living at a low cost. Yeah. So it's somewhere that's manageable and it can be done. Of course, my favorite thing of all time, those who know me know I am a foodie. This was the first Malaysian word I learned when I came to Malaysia, makan. It means food. Malaysia boasts a very rich culture, very diverse. They have Indians here, Chinese here, Malays here, and each culture comes with its own food. So you can imagine if you've ever heard of the famous street food when you come to Kuala Lumpur, it's actually a tourist attraction. Yeah. And we have street food on the street between the hospital and my house. So every day when I'm walking home, it's my favorite hobby. I walk around stalls eating all sorts of food, trying to fill myself up with the food. And guess what? Number 19 will shock you. If you're a Kenyan passport holder, you can actually travel to Malaysia without a visa. So if you want to do a reconnaissance, you don't need a visitor's visa to come in. Actually, you can come through in case you were not aware about that. I think you already saw this from Prof. Amelia and Prof. Azurah. They've incorporated me into their department like one of them. We do lunches together. We've done a retreat together, fully paid for by the hospital. We have our own sports things. We had a obstetric and gynecology night, cultural night. I was able to represent Kenya. So it's an all-round amazing experience. This is a great team. It's a great team to be a part of. It's not, of course, easy to be away from home. I had to leave my family behind. But I say, if you pursue your passion and, you let go of just a few attachments, then the possibilities that you can step into are beyond what you can think, beyond what you can imagine. And that's the experience that I've had having this small family and joining this Malaysian family. And I hope through this webinar that we'll have more and more people joining in as well, not only PAG, but even in all the other subspecialties going forward. With that, I'd like to hand over the meeting back to Dr. Kireki and Prof. Amelia to just give us parting shots before we call it off. And if there's any questions that anyone would want to ask, we have a brief period of a Q&A. Thank you very much. Over to you, Dr. Kireki. Or if there are any questions, if anyone has a question, you can ask meanwhile as we wait for Dr. Kireki. Okay, Prof. Amelia, you want to go first?
I would like to say that high-risk pregnancies are any pregnancy which there is a maternal or fetal factor that may adversely affect.
Oh, sorry.
Sorry.
No, sorry.
No.
Thank you, Susan, for that lovely presentation. I think we're all looking very much forward to a collaboration between Malaysia and Kenya. This is our first beginning of hopefully a beautiful relationship. And hopefully we can do many things together. Maybe we can have some more educational, joint educational activities. We can also, me and Azurah are dying to go to Kenya, of course. And we are hoping that this will be the beginning of research collaboration between the countries. Prof. Kireki.
Hello, thank you very much, Susan. I was attending to a small emergency. You know how patients are, but I'm back online. I want to thank you all for coming, Susan and our dear professors, your teachers. We are grateful. We are grateful because of, as they say, a journey of 1,000 miles starts with one step. And I think this is a step in the right direction of popularizing and making other people know, especially our colleagues, about the programs that are available and also the opportunities which are also beckoning. As Professor has just said, she's looking forward to collaborations with us and from us. And I want to say here, you know, without any fear of contradiction, as it were, that we are more than happy to support this, and we'll support all our colleagues who are willing to go in this direction that Susan has taken, and the very magnanimous professors from the other, from Malaysia. We also would like to also welcome you, professors, to our COGS meeting, which is starting next week. The last time we met, you know, I'm sure we talked about this, but of course, the notice was too short. But in the future, going forwards, I would like, I can see this being a collaboration whereby we present, research outcomes which have been done together in Kenya and in Malaysia. And I'm also looking forward, that is maybe one of the things that we can look forward to, is to having a tract or even a plenary session where we only talk about pediatric adolescent, gynecology. I want to thank all of you for taking your time. And looking at the numbers, I think there is a lot of interest. There's a groundswell in this. And I think we can continue working on this basis that we have formed today. We had planned for this to be a little bit longer, but since it was at the beginning, we are going to build on it and hold more CMEs together. Thank you very much for the information that you've shared with us. We do not have any sponsor, so whoever will be a future sponsor, we want to thank you in advance as well. Thank you so much. I don't know what time it is in Malaysia, Susan.
Can we take a photo? Azurah is very good at taking photos. This is our first joint event together. Can we take a photo?
Yes, please.
Who wants to show their videos? Welcome to. Azurah, can you take the photo?
Yeah, I can take the photo. Okay. So if everyone can on their camera so that we can all take the photo together.
Now, how do we hold the camera? Okay.
I will take, and
Azurah will share with Susan. And Susan
anyone else who wants to on their cameras before I take the photo? Thank you, Susie. So many lovely faces.
That is something we need to learn from you. Yes. And Susan, heartfelt congratulations for bringing this together. I know it has been a bit of up and down, especially with us organizing our annual Congress, but it has come to fruition, and we're very happy about that. So thank you for this inaugural meeting, and we are looking forward to having many more. And of course, that collaboration that we've talked about and the exchange, and if there are any scholarships that our colleagues can make use of, please feel free to contact Susan, and I'm sure she'll be of help. Thank you very much. And we say asante sana. I don't know what you say in Malaysian. Thank you.
Terima kasih.
Makasih. Okay, we learned that.
All right.
Okay, thank you very much. And bye-bye.
All right, thank you. Bye-bye.
Are you finished with the photo, Azurah?
Yeah.
Okay. All right.
All right.
Okay. Bye-bye.
Bye,
Bye-bye.
everyone.
Bye-bye. Thank you, everyone.
Have a nice
Bye.
season.